Welcome back to video 27.3 in our series on fungi. We will now be talking about endemic fungal infections. If you recall, these three thermally dimorphic fungi have a similar pathogenesis and clinical presentation to tuberculosis infections. The conidia are inhaled into the lung, causing a granulomatous response that can present in many ways, varying from asymptomatic, acute, disseminated, or chronic infection pictures. Because these three infections can seem similar to one another, for each entity focus on remembering the area of distribution and the microscopic morphology of the organism. Now, let's hop on a plane and fly to the middle of Kentucky. Why in the world are we going to Kentucky, you might ask? Spelunking. That's right, we're going to explore some caves. As we go down the cave, we soon notice that we are knee-deep in a sticky substance. Guano. Take a deep breath. Do you smell that? That's the sweet smell of histoplasmosis hiding out in the caves. Histo loves to hide. Histoplasma capsulatum grows in humid and acidic soil that exists in particular geographic areas, especially in soil that has been enriched with bird or bat droppings. We will be discussing the capsulatum variant of Histoplasma capsulatum, which is the one found in North America. Histoplasma capsulatum grows mycelia in the soil that produces macro and microconidia. When the soil is disturbed, microconidia are aerosolized. When inhaled, the conidia are small enough to then enter the alveoli. The capsulatum designation is actually a misnomer. These are not encapsulated organisms, but in tissue sections that reveal the yeast, there is a shrinkage artifact which creates halos around the yeasts, making it look like they have capsules. Histoplasmosis is the most prevalent endemic mycosis infection in the Americas. Histoplasma mostly occurs in the Ohio and Mississippi River valleys. There's a high risk of exposure for individuals that participate in activities such as spelunking, cleaning chicken coops, remodeling old buildings, or cutting down dead trees. Once inside the lungs, the conidia are quickly phagocytosed. Dendritic cells kill the conidia, but inside macrophages the histoplasma inhibit phagosome-lysosome fusion, increasing the pH to a neutral, non-lethal range. There goes the histo hiding again, this time inside of macrophages. Inside the macrophages, the conidia convert into budding yeasts and capture intracellular iron and calcium from the macrophages. The body attempts to contain the infection via granuloma formation. Some yeasts, however, use the macrophages as vehicles to translocate through the reticuloendothelial system. They mostly travel to local lymph nodes, but they can also travel to distant lymph nodes, the liver, the spleen, bone marrow, or peripheral blood. In disseminated disease, they can travel to any area. Wherever the yeast travel, granulomas may be found forming. Infected individuals develop Th1-related cell-mediated immunity, making subsequent infections with histoplasma less successful. Along that same line, yeasts hiding within macrophages may reactivate if the host later becomes immunocompromised. The clinical spectrum of presentations of histoplasmosis follow four basic paths. The first is asymptomatic, or perhaps a mild cough. Acute histoplasmosis is a description for people that suffer a flu-like illness. This occurs 1 to 4 weeks after the initial exposure. Chest radiographs like this one show mediastinal and hilar adenopathy with focal to diffuse densities, depending on the size of the inoculate. Review of systems in these individuals also reveals rheumatological symptoms. This is secondary to systemic cytokine release. Rarely, individuals can have more serious sequelae from acute histoplasmosis. The third entity, chronic cavitary histoplasmosis, is seen almost exclusively in patients with pre-existing structural lung disease. These patients experience chronic weight loss, cough, dyspnea, relapsing and remitting fever, and night sweats. The chest X-ray can be indistinguishable from tuberculosis, with mostly upper or lower lobe infiltrates, like those seen in this X-ray, cavitation, and pleural thickening. Disseminated histoplasmosis occurs mostly in immunocompromised individuals. These patients present with multi-organ system dysfunction. On physical exam, they might demonstrate hepatosplenomegaly, meningismus, or painless ulcerations of the oral mucosa, or ulcerations of the skin. Culture is the gold standard for diagnosing histoplasmosis. In disseminated histo, cultures are most commonly taken from a bronchoalveolar lavage or from blood. However, it seems bone marrow aspirate has the highest yield. Fungal stains may also reveal fungi in about half the cases of disseminated histo. Detection of the histoplasma antigen in the urine or the serum is extremely useful, with a sensitivity of 95%. Serologic studies are useful in diagnosing chronic disease or in acute disease if one can demonstrate a precipitous 4-fold increase in antibody titers. For mild to moderate acute histoplasmosis, first-line treatment is itraconazole. For chronic cavitary histoplasmosis, itraconazole is also used, but for a longer course. Severe histoplasmosis, histoplasmosis with CNS involvement, or disseminated disease require an initial course of treatment with lipid amphotericin B before switching over to itraconazole. Now let's get out of this cave. So, where to now? How about to a state that is home to beer, brats, and Green Bay football? Bingo, Wisconsin. Now it might be called the Badger State, but you better believe that I'm headed there to visit a bunch of beaver dams. Because beaver starts with B, and blastomycosis loves bees. Blastomycosis is a systemic pyogranulomatous infection involving primarily the lung. Like histo, the presentations of this illness range from asymptomatic to acute to chronic to disseminated disease. This thermally dimorphic fungi has yeast with thick walls that reproduce with broad base budding. This soil-based organism's endemic areas include the southeast, south central, midwest, and some northeastern areas, as well as in some Canadian provinces. Point outbreaks have been associated with areas where wood is decomposing. Unlike histoplasmosis, which can live inside of macrophages, the conidia of blastomycosis are highly susceptible to phagocytosis-mediated killing. This innate immune response is reflected by the high frequency of asymptomatic blastomycosis exposures. If the conidia do escape, however, they quickly convert into the much more resistant yeast phase. Once in the yeast phase, the big, thick, double-walled structures with their broad base buds are difficult to phagocytose at all, and so they exist mostly extracellularly. Blastomycosis expresses an adhesin that is an essential virulence factor, acting as a major epitope for humoral and cellular immunity. Our immune system's interaction with this epitope is ultimately responsible for the PMN infiltration and granuloma formation that accompanies blastomycosis. As we said, most inoculations are asymptomatic. Acute pulmonary blastomycosis is characterized by an abrupt flu-like illness. A chest X-ray will reveal infiltrates, but because the macrophages are not carrying the yeast throughout the reticuloendothelial system, hilar adenopathy is less common. Chronic pulmonary blastomycosis may closely resemble malignancy or tuberculosis. The chest X-ray may show cavitations or mass lesions mimicking bronchogenic carcinomas, as well as fibronodular infiltrates. Disseminated disease occurs mostly in immunocompromised individuals and is associated with diffuse lung involvement. There are many extrapulmonary sites that can be involved in disseminated blastomycosis. The most common site is the skin. The bone is the second most common location to be involved in disseminated blasto. The third most common site of involvement is the genitourinary tract. The entire GU tract may be involved, but the prostate and epididymis are the most common location. CNS involvement occurs in less than 5% of immunocompetent individuals, but over 40% of immunocompromised individuals will experience CNS symptoms. The gold standard for diagnosing blasto is culture. However, this takes up to 4 weeks. A second way to diagnose blasto is direct microscopic identification. It's worth noting that antigen and DNA tests are commercially available for blastomycosis, but they have not yet gained wide acceptance. Similar to histo, itraconazole is the treatment of choice for blastomycosis. Severe disease require amphotericin B as the initial agent before switching over to itraconazole. Refractory disease or brain abscesses are often treated with voriconazole or fluconazole. I think it's time for warmer climates. So let's head off to sunny Arizona. In the mid-1990s, when my dearly departed grandmother was in her late 70s, she decided to move to Phoenix. Why move to Phoenix? Well, because I think that's what old people do. Around Christmas every year, she would then send us a large crate full of pomegranates. Now that I think about it, that's a pretty strange thing to send. But, putting the rationale of her gift aside, if we can just remember this story of my kooky grandmother moving to Phoenix and then sending pomegranates to us, I think we can remember a lot about coccidioidomycosis. You'll see why in a moment. Coccidioidomycosis is an infection caused by the thermally dimorphic fungi of the genus Coccidioides. The clinical expression of the disease ranges from asymptomatic to acute pulmonary to chronic pulmonary to disseminated infection. There are 2 species in the genus Coccidioides that cause the disease. They are virtually indistinguishable with regard to clinical presentation, so we won't mention the species names again, only the genus. Coccidioides grow between the latitudes of 40 north and 40 south in the western hemisphere. In the U.S., that includes large portions of California, southern Nevada, Utah, New Mexico, Arizona, and western Texas. Areas of high endemicity are also found in Mexico, Central and South America. Infection may occur when individuals have direct exposure to previously undisturbed soil. A climate factor also seems to be in play, as there is often an increase in the number of cases in periods following rainy seasons. Most longtime inhabitants of endemic areas are exposed to coccidioides. We know this because there is a strong cell-mediated immunity that occurs in immunocompetent individuals that may be tested for with a hypersensitivity skin test, similar to a PPD used to detect exposure to TB. There has been a gradual yearly increase in the incidence of coccidioidomycosis in the Southwest, and this likely corresponds to an influx of previously unexposed, often slightly immuno-incompetent older adults moving to the Southwest. Does that remind you of anyone's granny? In the soil, coccidioides exist as filamentous mycelia. Older hyphae from the mycelia fragment into barrel-shaped viable elements called arthroconidia. These 2 to 4 micrometer arthroconidia may aerosolize and then survive in harsh conditions for long periods of time. Once inhaled, they travel into terminal bronchioles. Conidia evade mechanical defenses and pass through defects in the mucosa. PMNs, however, can phagocytose and kill even before an adaptive response is mounted. In the terminal bronchioles, the surviving arthroconidia become round, large, and septate structures called spherules. The large size makes them resistant to phagocytosis. Inside the spherules, there are numerous tiny uninuclear elements called endospores. This spherule endospore structure, to my eye, closely resembles a pomegranate. Thanks, Grandma. Mature spherules eventually rupture, releasing the many endospores into the body. Endospores are resistant to innate immune defenses. If an adapted response is mounted, it results in necrotizing granuloma formation. This effectively kills the endospores. Surviving endospores, however, eventually become spherules, and the life cycle is started again. Lifelong immunity develops in most individuals who become infected with coccidioides. 60% of people inoculated with coccidioides remain asymptomatic. Slightly less than 40% will manifest with primary pulmonary disease, also known as valley fever. 2 to 6 weeks after the inoculation, they will begin to present with an entity that looks very similar to a community-acquired bacterial pneumonia. More severe infections might be accompanied with night sweats or profound fatigue. Chest X-ray will reveal this pulmonary disease as focal opacities with mediastinal and hilar lymphadenopathy. About 10% will also have pulmonary effusions. The most common extrapulmonary symptoms is cutaneous involvement, which occurs in about 10% of individuals. Some patients will also have musculoskeletal involvement. With primary pulmonary infection, labs commonly reveal an eosinophilia. Nodules and cavities are common sequelae. More serious sequelae are rare. Less than 1% will present with chronic or disseminated disease. Chronic disease occurs almost entirely in individuals with pre-existing lung parenchymal disease. It presents similar to tuberculosis or malignancy. A chest X-ray will reveal increased pulmonary scarring from the patient's baseline. Disseminated disease occurs mostly in immunocompromised individuals and is notable for a much more diffuse involvement of the lung. Extrapulmonary manifestations may occur in a wide range of tissues. Culture is the gold standard of diagnosis. Examination of the sputum will reveal spherules in a significant percentage of patients with pulmonary disease. There are numerous commercial serologies available for coccidioides, and they are all relatively sensitive and specific. Serologies are still useful in endemic areas because patients lose serologic reactivity within weeks of an exposure, and so any positive serology indicates an active and very recent infection and is therefore clinically relevant. This is in contrast to the hypersensitivity skin test, which remains positive for life. As we mentioned, mild infections resolve without pharmacologic intervention. For patients with more moderate infections, fluconazole or itraconazole are equally effective. Severe pulmonary disease are often treated with a course of amphotericin B before switching to itraconazole or fluconazole. Now let's move on to those opportunistic fungal infections. See you soon.